There is a moment in clinical work, right after the intake and right before the diagnosis, where we make a decision that can change everything for our clients. And most of us were never trained to ask the question that matters most in that moment. Is it actually a mental health problem, or is it something medical driving every single symptom sitting in front of me today? I want to walk you through the medical conditions I see most often hiding behind mental health presentations. And I'm going to tell you what the research says, because this is not just a clinical intuition. This is documented, peer-reviewed, and largely undertaught in our field. I'm Heidi Hill. I'm a licensed clinical social worker with credentials in Georgia, Ohio, and New York. I'm also a certified sex therapist and addiction counselor, and I'm currently completing my PhD in clinical sexology. My entire clinical framework is built around one question: is it medical or mental? Because in 20 years of practice, I've seen too many clients spending years in therapy for something that needed a referral and a lab panel. Let's talk about that. This is actually extremely personal for me. In 20 years of treating mental health issues, I found myself feeling depressed. I couldn't do the dishes, the laundry, extreme brain fog, no motivation and energy. I started to isolate and pull away. And actually, I even quit my job after 11 years that I loved. Turns out I wasn't depressed. I was dying in my sleep. My oxygen levels were 66% at night. My brain was starved for oxygen, which impacted every aspect of my body. What I want to talk about today is obstructive sleep apnea. And I want to start here because it is the most underdiagnosed condition I see presenting as a mental health problem, especially in women. Here's what sleep apnea looks like in your therapy office. Persistent fatigue that doesn't respond to sleep hygiene interventions, concentration and memory problems, irritability and mood instability, low motivation, depressed affect, decreased libido. Sound familiar? It should, because that is also the symptom picture for depression, ADHD, and generalized anxiety. The difference is that no amount of CBT is going to fix a blocked airway. What the research says, women who were treated for sleep apnea with CPAP therapy showed significantly larger improvements in sexual quality of life versus men. Women are the bigger responders, which tells us that untreated sleep apnea is quietly suppressing women's functioning in ways we are not even screening for. And here's what makes this worse. The classic sleep picture of sleep apnea we are taught was a middle-aged man who snores. Women present differently. They report fatigue, mood changes, and insomnia more than snoring, which means they are referred to therapy instead of sleep apnea. Often I hear people come in and they're just struggling, especially females or males that live by themselves. They often don't even realize that they're struggling with this problem and that they're not depressed or not anxious. It's just that they're not breathing at night. That is a key component to ask and screen for. A client presenting with fatigue, mood, instability, or low libido, how is your sleep? Do you wake up feeling rested? Are you getting up in the middle of the night to use the bathroom? Has anyone ever told you that you stop breathing or snoring? And if the answer raises flags, refer the sleep study before you build a treatment plan. And diagnosis. An area I want to cover is hormonal changes, specifically perimenopause, one of the most misdiagnosed presentations I see in clinical practice. Perimenopause typically begins in women early in their mid-40s, but I've seen it even earlier as the late 30s as well. And mental health symptoms pictures can be significant. Here's what perimenopause looks like when it walks into your office. Anxiety that seems to come out of nowhere, panic attacks with no clear trigger, depression that doesn't respond to standard treatment, rage, disproportionately sudden and confusing the client. Emotional lability. Many of these women have never had mental health histories. They are confused, often ashamed, and they have usually never been told that their labs are abnormal with their primary care provider. Often those labs are being missed. What the research says that the relationship between estrogen functioning and mood is well established. Estrogen plays a direct role in serotonin regulation. So when estrogen becomes erratic during perimenopause, so does the mood. A review in the Menopause Journal found that perimenopause women have significantly elevated risk for depressive symptoms even without a prior history of depression. This is not a character flaw. This is endocrinology. What to do clinically? Ask every woman in her late 30s through 50s about her cycle. Is it changing? Is it irregular? Is she experiencing hot flashes, night sweats, vaginal dryness, alongside with mood symptoms? A referral to a gynecologist or an integrative medicine provider who specializes in hormonal health care can be genuinely life-changing for these clients. You do not have to manage the hormones. Postpartum is our third area that we're going to talk about. And this one covers a lot of ground because the hormonal shifts across pregnancy and postpartum periods are dramatic and rapid. During pregnancy, anxiety is actually more common than depression during pregnancy and is under-identified because we tend to normalize worry in expectant mothers. But clinically, anxiety during pregnancy, racing thoughts, physical symptoms, difficulty functioning is not just normal worries. It needs to be addressed and treated. Baby blues, tearful, emotional, sensitive for the first 2 weeks is a hormonal response to a dramatic drop in estrogen and progesterone after delivery. It typically resolves on its own. Postpartum depression is different. It persists beyond 2 weeks, involves significant functional impairment, and requires treatment. Postpartum anxiety is often missed as well. With intrusive thoughts, hypervigilance, and an inability to rest, they are sometimes told this is just being a new mom. Postpartum psychosis is rare, but a medical emergency. Disorganized thinking, hallucinations, a rapid mood shift in the early postpartum period requires immediate psychiatric evaluation. What the research says is postpartum depression affects approximately 1 in 5 mothers. A meta-analysis published in JAMA Psychiatry found that perinatal depression is significantly underdetected and undertreated, particularly in women of color and women without access to specialty care. Screening matters. The Edinburgh Postnatal Depression Scale takes 5 minutes and gives you real clinical information. Very important to screen every prenatal client during a pregnancy and postpartum appointment. Know your referral pathways for perinatal psychiatry in your area. And ask about intrusive thoughts because clients will often not volunteer them out of fear of judgment. I also want to talk about thyroid dysfunction because it's extraordinarily common and extraordinarily missed, especially after pregnancy. The thyroid regulates metabolism, energy, mood, and cognition. When it's underactive hypothyroidism, the clinical picture looks like depression, fatigue, cognitive slowing, weight changes, cold intolerance, hair loss. When it is overactive hyperthyroidism, it looks like anxiety, panic, racing heart, insomnia, irritability. Lead to the therapy office and receive a mental health diagnosis without anyone ever checking their labs. What the research says is that thyroid dysfunction, even subclinical cases where levels are slightly outside the range, was associated with significant mood and anxiety. Subclinical hypothyroid is particularly frequently missed because it falls just outside the normal range and many providers do not treat it. Ask your clients, has your thyroid ever been checked? When was the last time? If it's been more than a year and they are presenting with symptoms that picture similar to what we listed, ask them to request a full thyroid panel, not just a TSH. Sleep apnea, perimenopause, perinatal hormone shifts, thyroid dysfunction, these are not rare conditions. They are sitting in your caseload right now, and they are presenting in a way that can look exactly like the mental health diagnosis we are trained to treat. Our job is not to be physicians, but our job is absolutely to be curious. Ask enough questions. Is this really what I think it is? And if something medical could be driving this, am I making that referral? That question alone can change the trajectory of a client's life. If this is the kind of clinical thinking you want more of, follow this channel. I post regularly on the intersection of medical conditions and mental health because this is a gap in our training that costs our clients real time and real suffering.